Hello, everyone, and welcome to the Abnormalities of the Immune System in Cancer Patients. My name is Angela Austin with the Patient and Community Outreach team at the Leukemia and Lymphoma Society, and I will be your moderator today. We will have a question and answer session after the presentation where our speaker will answer questions from the audience. I'm now pleased to introduce Dr. Shahzad Mustafa. Dr. Mustafa is the Chief of Allergy, Immunology, and Rheumatology at Rochester Regional Health in Rochester, New York, where he sees both pediatric and adult patients. He's also on faculty at the University of Rochester, where he is Clinical Associate Professor of Medicine and the Clerkship Director for the Medical Student Elective in Allergy and Clinical Immunology. In addition to teaching and seeing patients, Dr. Mustafa is also a lead investigator on multiple clinical research projects with a special interest in secondary immunodeficiency due to malignancy and chemotherapeutics. On behalf of the Leukemia and Lymphoma Society, thank you for volunteering your time and expertise. Dr. Mustafa, I am now privileged to turn the program over to you.
Thank you so much, Angela, for the very, very kind introduction and for having me tonight, and for the LLS for, again, the invitation, and for everyone for joining. I know evenings are busy. It's a crazy time. The world is a little upside down. So thanks for carving some time out. My goal is going to be to make this very, very practical and hopefully answer your questions. And we will certainly have time at the end for Q&A. Feel free to put those in through the chat function throughout the talk. So a little outline, a little roadmap of what we're going to do over the next 45 minutes or so. We're going to talk about some background of immune deficiency, which I think is important to just understand, and then a proposed evaluation of immune deficiency, and then some therapeutic options. How can we manage this? This isn't just a talk about it. There's actually things we can do. I think my biggest disclaimer for the talk this evening is I'm not an oncologist. I'm a clinical immunologist, and I by no means want to manage your primary hematologic malignancy, but I do think clinical immunologists and oncologists can work very well together. So I'll try to give you a highlight of how that may look over the next few minutes. So if we're going to talk about immunity and defects in immune system, we should talk about some immune components. Your immune system is very, very complicated with lots of different parts. And I'm going to overly simplify it because that's actually how I understand it best. There's these proteins called complement proteins. These are proteins that help with innate immunity, very early response to danger, to signs, alarmins. Very, very, very few immune deficiencies are due to complement defects or defects in complement proteins. So we see it, we study it, we don't see a whole lot of it in clinical practice. Then you have neutrophils and phagocytes, which can also lead to defects, particularly things like abscesses and a predisposition to infections, often in children. Again, pretty rare. We don't see many of these defects and abnormalities in clinical practice. Now we're getting into two of the bigger parts, and T cells. So T cells are a very big part of our immune system, particularly in responding to viral antigens. We all know about a virus now, COVID. T cells are a big part of our immune system. Our ability to evaluate T cells is decent, not great, but we certainly see these abnormalities in clinical practice. And then really the biggest part of the immune system that we're going to spend a lot of time talking about today is our antibodies. Antibodies work with T cells. They help with viral infections, but certainly bacterial infections. We are very well equipped to study antibodies, measure levels, measure function. And many individuals with blood cancers, B-cell malignancies have antibody defects, and a lot of our therapies lead to antibody defects. So this is really going to be the biggest focus of the talk tonight. And that's why I've the font sizes kind of categorizes how relevant this is. So immunologists take care of a lot of conditions called primary immune deficiency. You guys have heard of the bubble boy in pediatrics. So, severe combined immune deficiency, and then there's secondary immune deficiency. So primary immune deficiencies we study a lot about, but they're pretty uncommon. We only have a handful of patients in our practice with primary immune deficiency. Secondary immune deficiency is hugely common. There's millions of individuals just in the US with secondary immune deficiency, so much, much more common. Primary presents in, again, many children, 2, 3, 4, 5 years of age. And then there's a second level of presentation in individuals in their 20s, which as I get older, 20s is way young, so young adulthood. Secondary presents much later in life, typically fourth, fifth, sixth, seventh decades. And because this presents later in life is due to the reasons it presents from, and we'll talk about that. We know a lot about primary immune deficiency. We know a lot about genetic defects. We know how we should evaluate it, and likely we treat it, all right? Secondary is really poorly defined. We don't know a lot about what causes it potentially, how do we evaluate for it, and how do we treat it? And when we don't know a lot in medicine, we start seeing different people doing different things. So that's why I'm going to try to ground this conversation today on a proposed approach to evaluating your immune system in the setting of blood cancers, chemotherapies, things like that. So again, there's been a lot of talk recently about individuals who are immunodeficient or people with immune deficiency, and this can range a huge spectrum of things. Children are immunodeficient. Their immune systems mature over the first few months of life. Elderly, advanced age, as we get older into our 8th and 9th decade, our immune system actually has some glitches, so we become somewhat immunodeficient. Multiple conditions, diabetes has mild components of immune deficiency. Certainly malnourishment is a leading cause of immune deficiency in third world countries. Our antibodies are proteins, and if you're malnourished, you can't make protein. So there's a lot of reasons to be immune deficient. We're going to really focus on blood cancers, which fortunately I think you guys are familiar with: myeloma, lymphoma, and CLL. And then medications. The most common medication that can mess with antibody levels is actually prednisone or steroids, a medicine many of us have gotten for asthma or croup or poison ivy. But we're going to talk about some specific medications used in the treatment of blood cancers, particularly B-cell depleting agents, rituximab and ibrutinib. So lots of reasons for immune deficiency. We're going to really focus in on blood cancers and certain medications. So I don't give many talks where I quote a study from 1973, and there's a point of that. The point is, this is not a new thing. We've known this. This table is just a table of individuals with multiple myeloma, CLL, and heart disease, MI, myocardial infarction. About 50 individuals in each group. And what this table shows is the risk of infection in this group, all right? So the risk of infection and the amount of infections in people with myeloma is much, much higher. Same with CLL compared to heart disease. So the point here is individuals with myeloma, CLL, lymphoma have a much higher risk of infection compared to normal controls or their peer group. As you see, pneumonia here, 73-54 compared to just 8. Importantly, as we get older, the risk for infection in this group gets even higher, all right? So under 50, it's much higher than individuals who have heart disease. It's much higher throughout, but it really gets pronounced as we get older, over 70. So lots of infections. What are the most common? By far and away, the most common infection seen in individuals with blood cancer is sinopulmonary infections. Pneumonia is the most meaningful one. Sinusitis is the other one. Lots of upper airway and airway inflammation. So these are very, very common. And these can be a significant cause of actually dying from your cancer, or certainly complications with your cancer. So what are we doing about it? We know this. We've known this for decades, that infections remain a leading cause of complications and death in cancer. So we know about infections. We know which one, right? We talked about it. Pneumonia remains our biggest one. What's the bug? We know the bug also, Streptococcus pneumonia. We have vaccines against this, right? Maybe you guys have received your Pneumovax or your Prevnar. This is what we are doing to prevent infections in individuals with B-cell malignancy. What's happening though? The #1 cause of complications and death in individuals with blood cancer remains infection with pneumonia and strep pneumo, despite our best efforts of vaccination against pneumonia. So clearly the current state, it's not working. We've got to do better. Why isn't it working? It makes sense if we stop and think about it. So what about vaccination in blood cancers? What do vaccines do? When you get injected with a vaccine, your body builds antibodies. I think we all know a lot more about this today than we did 2 years ago with COVID. We've heard it constantly on mainstream media, right? Antibody levels, antibody levels. So vaccines lead to antibody production. How do we make antibodies? B cells in our immune system make antibodies. All right. T cells don't really make too many antibodies. B cells are the major part of the immune system making antibodies. Well, what are CLL and lymphoma or myeloma? These are actually B cell cancers. The B cells are abnormal. So we're asking abnormal B cells to make antibodies in response to vaccination. And they don't do a very good job of it. Unfortunately, this is before COVID. We've known for a long time individuals with blood cancers like CLL, NHL, multiple myeloma, they respond suboptimally to vaccinations. They don't build antibodies like normal controls. This is very, very important. So vaccination, although recommended, and although I absolutely think everyone should be vaccinated for many reasons, which we'll talk about, the response is suboptimal. I'm just going to show you one study. This is a group of about 30 individuals with CLL who we measured their antibodies to pneumonia here, okay? This is pre-vaccination, and then we vaccinated them. Typically, you would see these levels shoot up. In individuals, they usually quadruple, at least double, all right? Look at this group of individuals with CLL. These levels are the same before and after. They never even responded to the vaccine. What about for Haemophilus, H flu? Some people here in this group of 30 bumped up. That's great, but most stayed pretty similar. Tetanus vaccine, right? We all get our tetanus shot every 10 years. We bounce way up in our antibody levels. Not individuals in this study with CLL. And unfortunately, this study can be duplicated in lymphoma and myeloma and CLL over and over and over again for years and years. Even this reference is from 20 years ago. So this is nothing new. We've known this for a very long time. So if our primary means of preventing infection is vaccination, but vaccination is not working, what other choices do we have, right? Well, lots of people use prophylactic antibiotics, not treating the infection, but putting someone on a low dose antibiotic, maybe azithromycin, like a Z-Pak, maybe 2 or 3 times a week, rather than a higher dose, to prevent infection. This is commonly used. In fact, guidelines for CLL say this is usually the first step in individuals with CLL who have evidence of infections or who have evidence of abnormal antibody or immune deficiency. This is often the first step that you start with, prophylactic antibiotics. Azithromycin is commonly used, and other individuals may be on Bactrim or sulfa. The problem is the studies about how effective this is are all over the place, and they're not great. And we all know that being on antibiotics frequently, even low doses, has downsides, right? You get antibiotic resistance, you might get side effects. So it's not ideal. And in the world of infectious disease, our ID colleagues, or even our immunology allergy crew, we don't love the idea of individuals being on antibiotics chronically. But it is an option, it is an approach, and it's something I certainly use, and it is recommended by guidelines in certain individuals. So if you're not going to use prophylactic antibiotics and someone is having infections or someone's not making antibodies and they have low antibody levels or immune problems, what else can you do? You can give them antibodies. You guys may have heard of immune globulin replacement, IVIG. People say IVIG, but there's other forms of IG, and we'll talk about that. So this actually comes from blood donors. Individuals donate blood. We collect their plasma. Their plasma has antibodies in it. We refine it, put it together, and then give it to individuals. Just like blood transfusions, this is instead antibodies only. So there's all these guidelines on when and when not to use immune globulin replacement in individuals with blood cancer. And the key here is certainly if you're having recurrent or severe infection and if your antibodies are low. But I'm going to show you in the next few slides through a couple of studies we've actually done, the number of your antibody is not always the most important thing. And this recommendation is based on the number. What we care about is the function of your antibodies, right? Think about it this way. If you have a big army, a huge army, but it's lazy, that doesn't do you any good. Conversely, you could have a small army, but it's great. I'd rather have a small army that's great than a big army that's lazy. So the number is just telling you the size of the army. What we really want is function, all right? And we're going to talk about how to do that. And this, I will say, working closely with my hematology colleagues is something very different in the hematology world versus the immunology world. And this is why I think we should work together. This is just a study that shows over Europe, US, Canada, multiple regions globally, what are people doing? Some people are doing no treatment prophylactically, proactively. Some people are doing a lot of antibiotics. Look at the gray. There's a lot of antibiotic use proactively. Some are doing immune globulin. They're giving the blood products, right? The blue. And then some are doing both. But look at these. Like it seems like it's all over the place. Some are doing it before infection, some are doing it after infection. So the point of this slide is there's a lot of differences in how we're practicing. And it makes me nervous when doctors taking care of the same conditions are doing it a bunch of different ways, because that means we probably don't really know our way and we're guessing a little bit. So this is a suboptimal management, a very heterogeneous management for similar conditions. So this is very important. This is a proposed immune evaluation. This is what we do for our patients here in Rochester, Rochester Regional Health, and UVAR. If we have published data on it, but this is a proposed immune evaluation. Again, you need to take this back to your primary physician, your hematologist, if you work with a clinical immunologist. But I think checking antibody levels is not controversial, and most individuals who have a blood cancer have had antibody levels checked. You may be familiar with your IgG level or your IgM or your IgA. That again is the size of your army. It doesn't tell you anything about function. What I really care about is your function of your army. And the key here is checking vaccine responses. This is something immunologists have been doing for decades, but is less commonly done by our hematology oncology colleagues. We don't just want the size of your army, but how does it work? So we will actually check your levels against something like pneumonia or tetanus or diphtheria or meningitis, what have you, hepatitis. Then we vaccinate you. And then 4 weeks later, we check your levels again. And what they should do is go way up. And that's great. It tells us your antibodies are working. If your levels don't go up after vaccination, that tells me you have a glitch in your immune system. And sometimes you can have very normal levels of antibodies, but they don't work that well. And then there are T cells, and I talked about earlier, T cells and B cells work together. They work hand in hand. So we should check what we call lymphocyte subsets. And this is something immunologists do, and I think many oncologists do as well. So the question sometimes comes up from my colleagues is this individual has CLL or lymphoma. They're not having infections. Why, Shahzad? Why should I check all this stuff? Why do I even want to know? Well, one of the reasons is even if someone's not having infections, these levels, these very simple levels that can be completed in any lab, I'm not asking for fancy labs here, these levels are part of helping predict prognosis in CLL and potentially in lymphoma and myeloma as well. Anytime someone gets diagnosed with cancer, you guys know this better than me, usually one of the first questions is, hey doc, what's my prognosis? And these levels will help you predict prognosis. This is for IgG. Individuals with CLL at the time of diagnosis who have lower IgG levels, these lower levels compared to the higher levels, tend to do worse. And that's very, very important. I think we should know that up front. But other than that, we can find out tremendous information about your immune system, which is ever so important, which we've really, really come to appreciate in this world of COVID, which I'm going to certainly touch upon. So I'm going to show you two parallel studies that we did at our center, very, very small studies, but they're proof of concept studies. I want to get the point across, and they'll hopefully lead to bigger studies. One is using immune globulin in individuals with lymphoma who have been treated with rituximab. So this is just 15 individuals, not a big study, doing well. Their last cycle of rituximab, you see, was anywhere from a month ago to almost 2 years ago, all right? So the distance from their last cycle to rituximab is kind of all over the place. What we showed is, again, these are individual patients looking across, so 15 patients, right? Look at their IgG level, that's their antibody level, right? It's pretty good. Some people are a little low, 300, 1100 is normal. Anywhere above 700 is normal. So we have some low numbers, but they're pretty good. The average is 628, pretty good. So these individuals with lymphoma treated with rituximab, their antibody levels, not bad at all. Little low, nothing crazy, nothing that would catch my attention. Their IgM and IgA is actually really good. But check out their function. Despite normal levels, when you vaccinate them for diphtheria, check it out. Only 20% respond to the vaccine. The rest don't bump their levels at all. Tetanus, 1 out of 15 of these individuals responded to the vaccine. Pneumonia, 1 person, 2 out of 15, 3 responded, so 20%. So the point of this is in individuals who've been treated with rituximab, which is used commonly in oncology and rheumatology and neurology and other conditions for nephrology, your levels of your antibodies may not drop, but your function is really not so great. So what did we do in these individuals? We gave them immune globulin. We gave them antibody infusions. And not shockingly, just in the 10 that I'm showing here, their levels, their IgG levels went up. That's not surprising. We did it for a year and then we stopped. And then most people, when you stopped, came down. 1 individual went up. So what that suggests is in a small percentage of people, as you get further away from your rituximab, your immune system may recover. But unfortunately, for most people who are treated with rituximab, your immune system doesn't really recover as quickly as we'd like, 6 months, a year, even longer. Probably not so much immune recovery. All right, so we found that your immune system was a little sleepy. We gave it antibodies and improved the levels. Did it matter? Yeah, it cut down on infections in these 10 individuals. It cut their infections by half. Now, again, very small study. I'm not a statistician, but I know this study is not powered to say that this treatment will decrease infections. But just looking at it qualitatively, there is absolutely a decrease on antibiotics due to immune replacement in individuals whose levels are decent, but their function is not so good. Same exact study in individuals with CLL, just published this year in PLS1. Same concept, 15 individuals, they have CLL. Check it out. This is pretty mild CLL, generally early watch and wait, which I hope many of you are in. Many individuals with CLL are in watch and wait. 1 individual was on ibrutinib, which is a common therapy. Even at the time of diagnosis for CLL, even in watch and wait, many individuals have evidence of immune deficiency. Same exact graph, guys, looks a little different. 15 individuals, watch and wait for most, ibrutinib for 1. Their IgG average 782. That's normal, pretty normal levels. Did they respond to vaccines? Still not great. Less than half are responding to vaccines. So even in very early, mild watch and wait CLL with normal antibody levels, function is not great. Same thing, here we did it for 6 months. We gave these individuals immune globulin. Levels went up, just like we think. We're giving it to them. We're giving a diabetic insulin. We're giving, blood transfusions into someone who's anemic. Levels go up. We stop it at 6 months. 3 months after, levels come right back down. So again, the levels are going up because we're giving it, not because the disease is getting better or the immune system is recovering on its own. Here we even check levels against specifically pneumonia. Now remember I told you at the beginning, pneumonia is actually the most troublesome infection. So we really care about your antibodies against pneumonia. Look at how low some of these people started, really low levels. Went way up with treatment, came way down after treatment. So clearly we are improving antibody levels in general and specifically in this study to pneumonia too. What happened here? Exact same thing that you saw in the rituximab study. We cut antibiotic reliance in less than half. This is before treatment, this is on treatment, and this is in the 3 months after treatment. So antibiotics went down, we stopped treatment, antibiotics start going right back up. If we double this to 6 months here, it's going to get right back to here. So again, we're evaluating their immune system more than just the level with function. We're treating people proactively who are showing signs of immune deficiency, and we're cutting down on antibiotics. This is a suggestion. I am by no means saying individuals who are not having infection should be treated with immune globulin across the board. I'm not saying that. Every individual with CLL, lymphoma, myeloma should not be on immune globulin. But these are proof of concept studies that even in the setting of normal antibody levels, there is dysfunction, and there are things we may be able to do to improve outcomes. This is an important slide. A lot of people are familiar with IVIG, and maybe you guys are too, but are less familiar with subcutaneous Ig. And I'm going to show you some important considerations here. So immune globulin is just giving someone antibodies, right? Plasma products. There's many ways to do it, and there's many things it does. It decreases your rate of infections. It decreases antibiotic dependence. It decreases your risk of hospitalization. It does not prevent secondary cancers. Secondary cancers are actually a big complication with blood cancers as well, additional cancers. Immune globulin replacement does not affect that. And there are different routes of administration. Years ago in the 70s, we used to inject it intramuscularly. It hurt a lot. So we don't do that anymore. The vast majority of individuals who get immune globulin get it IV, intravenously. But I want to raise the awareness of subcutaneous, kind of like almost an insulin pump. So what does subcutaneous looks like? You put the immune globulin, you draw it up from a vial, you put it in the syringe, and you put this syringe in this pump. Clean off a part of your skin. You put this tiny little needle. It's kind of like an insulin injection. It's got tubing on it. You put this tiny little needle into your adipose tissue. Most people do it in the abdomen. You can do it in your thigh. You can do it in your arm. Put some tape over it. You put the needles in there now. You got this little tubing going to your pump. Push the drug in. This infuses. And you can do this. You can put this in your pocket. You can walk around. You can certainly do it at home. Most individuals do this on their own after they're taught. It takes 2 or 3 times. They do it on their own. They can do it anytime they want at home. You get rid of the needle. The deed is done. So what are the differences? So if you get IV, IG, you get a whole slug of drug. And then the levels come down, and then you get a whole slug of drug. So you get this sawtooth pattern. IVIG is typically dosed every 3 to 4 weeks. The subcutaneous stuff is hugely flexible. You could do it daily, but most people do it once a week, or you could do it once every 2 weeks, or even once every 4 weeks, you can do it. But because of the way it's administered, not into your veins, but into your subcutaneous tissue, it's more like a depot of medicine. So it releases slowly. So you get a much steadier level. You don't get these peaks and valleys that you see with IV. So that's a benefit, actually. This is the biggest reason I think sub-Q is the way to go. We don't do intramuscular. This is the percentage of meaningful side effects, real side effects. You can have infusion reactions, you can have anaphylaxis, you can have even like forms of meningitis with IVIG. So we don't do intramuscular, so we'll take that out. But when you do IVIG, up to 50% of individuals getting the infusions have systemic side effects. Flu-like symptoms are common, aches, pains, fevers. People take off of work for the day or 2 after their IV. Lots of side effects, up to half the time. You can be managed. They're not a big deal. We do it all the time, but they're there. Look at the frequency of side effects with the sub-Q. You can barely see it because it's rare. Sub-Q rarely has systemic side effects. So again, it's not right or wrong, but we need to know that these options exist. I think what's important in 2022 now is asking our patients what they want. And if you ask individuals on immune globulin, do you prefer IV or sub-Q? 80% will tell you they prefer sub-Q. If you're giving them the option. Then if you take it a step further, okay, you want sub-Q, you want to do it in my office, you want to do it at home. Almost everyone wants to do it at home because they can do it at home. It's safe to do it at home. It's well tolerated. It gives you patient autonomy. So again, patient preference is very important. So there's pros and cons to all of this, right? What's IV pros? You can really give a big dose, typically dosed once a month. So it's infrequent dosing. What's the disadvantages? You need IV access. You need a healthcare professional, unless you're starting your own IV, which you're not. There's a hugely increased risk of side effects. You get these peaks and valleys in your IgG level, and it requires medical resources. Many people get IVIG in an infusion center. That's never that ideal, but particularly in the world of COVID with social distancing and high risk exposures, that's not where you want to be. For subcutaneous, what are the advantages? You don't need IV access. You can self-administer it. It's much better tolerated, and the levels we talked about is much steadier. Patient autonomy. Individuals can be taught to do this in 2 to 3 sessions. It is pretty user-friendly. What's the downside? Well, I said historically, it's more frequent dosing rather than once every month. It's usually weekly, but there are new products that can be dosed once a month. I will say when you do IV once a month, a typical time for a typical dose is 3 to 4 hours. When you do sub-Q weekly, the typical time is 45 minutes to an hour per week. So the total time is similar. It's just how you want to break it up. Subcutaneous doesn't apply to everyone. Some patients may not want to do this. I have some individuals who want to come to our infusion center because our staff is amazing. They prefer that. But again, choices, choices, choices. I think choices are so, so important. So that's a little background on thinking about how the immune system works, the components of the immune system, antibodies, certainly evaluating for your immune system, how it works, antibody levels, antibody function. ways to intervene in individuals who may have immune deficiency, prophylactic antibiotics, immune globulin, ways of giving immune globulin, IV, sub-Q. And now we're going to kind of put this all into the context. And I wish I could spend an hour giving a talk these days without talking about COVID, but that is just not possible. So we're going to talk about all of this stuff in the setting of COVID, which certainly impacts every one of us, and particularly our high-risk individuals. And with individuals with blood cancer, they are high-risk individuals. So we started off way back when talking about people with blood cancers not responding to vaccines. How did they do with the COVID vaccine? So you see this as normal control. 99% of normal individuals who are vaccinated with COVID will demonstrate antibodies against COVID. Now you see these abbreviations: Hodgkin's lymphoma, myelodysplasia, CML, AL, multiple myeloma, non-Hodgkin's lymphoma, and CLL. So look at the percentages. After 2 mRNA vaccines, only 47% of individuals with CLL demonstrated antibodies. You were able to find antibodies if you measured them. That was the worst. Lymphoma was better, myeloma was better, normal controls, it's 99%. This is after 2 doses. Stay with me there. So only 50% were able to produce detectable antibodies for CLL. So 60% for 70% for lymphoma. Of the individuals who produced antibodies, what were their levels? Not only that many not produce it, but when they did, their levels were lower than normal controls. So again, individuals with blood cancers not only don't respond to the vaccine as well as we would like, but some don't respond with antibodies at all. That does not mean they shouldn't be vaccinated. It doesn't mean their response is 0. It's just suboptimal. Are there ways to predict who may respond to the vaccine or not? The best predictor is actually lymphocyte counts and your antibody levels, your globulin, your IgG, your IgA. The lower your level, the less likely you are to respond to a vaccine. So even though we're not great at measuring antibodies to COVID, we can use this as a surrogate. And this was a study literally just published last week of comparing just blood cancers, CLL, lymphoma, and myeloma. Our patients with myeloma tend to have a much better response to 2 doses of mRNA vaccine compared to lymphoma. And unfortunately, again, our patients with CLL, even early CLL, tend to be the poorest responses to COVID vaccination. Very disappointing. Does it matter if you're on therapy or not? Yes. If you're on therapy with CLL, your likelihood of responding to the vaccine is even lower than if you're not on therapy. So therapy is kind of the double whammy. It doesn't matter what therapy. It doesn't matter if you're on ibrutinib or rituximab or other agents like venetoclax, but therapy is certainly a risk factor for poor response in the setting of CLL. You guys are familiar with rituximab. This is a study from Rheumatology, but I just wanted to kind of bring out what it highlights about rituximab. Rituximab is anti-CD20. I know I'm speaking to a sophisticated group. So anti-CD20 is a marker for B cells. So rituximab knocks out B cells. So when you have B cell cancer, you have a lot of bad B cells making cancer cells. You want to knock out those B cells, and you do with rituximab. The problem is it takes good B cells with it, so you get lower antibodies. So in this rheumatology study, not oncology, but rheumatology, if individuals had received rituximab within the last year, only a third demonstrated antibodies to COVID vaccine. 2 doses. We're going to get to more doses, 2 doses. What was the biggest predictor of not responding to the vaccine if you're on rituximab? Check it out. Same thing. Low antibody levels, hypogammaglobulinemia. So many reasons to have these levels checked. Steroids a little bit, but this was the biggest. So blood cancers are a risk factor. Certain therapies, B cell depleting therapies, rituximab, risk factor. Problem is, sometimes we treat our blood cancers with these B cell depleting therapies, and that's a double whammy. So we're talking about vaccination, and we started with 2 doses. Now it's 3 doses. Heck, there's some stuff floating around about 4 doses. Where did that come from? This was one of the first studies published way back in the summer, which is eons ago in the world of COVID. It keeps changing week to week. This is individuals with solid organ transplant. They've had an organ transplant, they're on immunosuppression. And after 2 doses of the vaccine, you see that many have not responded to the vaccine, okay? So if you give them a 3rd dose, about a quarter of individuals will respond to the vaccine. This is in solid organ transplant. So many don't respond to 2 doses, but a third dose, a quarter of patients will respond and the levels will go way up, and it's very well tolerated. This was the initial impetus to say individuals, high-risk individuals, remember, should get a third dose of COVID vaccine. And then it brought into everyone. This has since been looked in CLL as well. And what you see here is individuals with CLL who've had 2 doses of vaccine have pretty low response rate. We've talked about that. A third dose increases the likelihood of cranking up on your antibodies by about 25%. So again, people with CLL tend to do better with antibody production from vaccine with 3 doses than 2. They're both suboptimal, I'm going to be honest, but 3 is better than 2. Can we predict who's going to respond to the third? Yeah, if you're not on therapy, active therapy, that's a good thing. Or if your antibody levels, we keep going back to these antibody levels, are normal, you tend to respond. So this is why individuals, this is one of the reasons with blood cancer should get 3 doses of vaccine, because you have a much better chance of responding to 3 doses than 2. Before I go forward, I want to mention one other thing that I want to, because I know this is a sophisticated crowd. We're talking about antibodies here, right? But remember that first graph with the 4 parts of the immune system? T cells are really important. And even in the absence of antibody response, we may be producing T cell responses, and we're not great at measuring that. So even in individuals who've been vaccinated with 3 doses, maybe 4 doses, and they know they don't have antibodies, they're worried about antibodies, it's very likely there is a T cell response. But please don't think the vaccines were useless. They're not useless, they're just suboptimal. And because of that, we want to protect you from COVID. So what are some other ways? So do not start immune globulin replacement to protect yourself from COVID, but people should know who are on immune globulin replacement, whether it's IVIG or Subcu-Ig. As of now, you are probably, depending on when you got your lot, where the lot came from, you're probably getting some COVID antibody in your immune globulin. From the time someone donates plasma to the time it gets to the product, it's about a 12-month delay, 9 to 12 months. So people who are getting immune globulin today, their donor gave blood in early 2021, which is when the vaccination campaign was starting, right? So in May, blood donors for immune globulin, most had antibodies. So by this May, most immune globulin products will have some amount of antibody. Is it enough antibody to protect you sufficiently? I don't know that. But I want people to know who are on immune globulin, you're getting a lot of antibodies in your immune globulin, that's why you're on it. But some of those will probably include COVID antibodies as well. What's another way to protect against COVID? Prophylaxis. If you're not getting antibodies from your vaccines, guess what? We can just give you the antibodies. This product received emergency use authorization just a couple of weeks ago, and we just started administering it to our patients last week. Very, very exciting. It's called Evusheld, all right? So this is 2 injections of COVID antibodies into you if you can't make them, and they last at least 6 months, maybe longer. And what the study shows is individuals with Evusheld are very unlikely in this study to get COVID, whereas individuals on placebo had a much higher risk of getting COVID. So again, Evusheld is literally giving individuals who may not respond to vaccination, blood cancer, rituximab, chemotherapy, immunosuppression. If you can't make antibodies from the vaccine, which is the whole point of being vaccinated, we're just going to give you the antibodies, okay? And it works really, really well. The study was done in the time of Delta. We have this crazy thing called Omicron now, which we all know has some immune escape, right? It's pretty different. Evusheld has adequate activity against Omicron, important point. The beauty of this is it's fantastically safe. The side effects were not that different than placebo. So really, really, really safe, effective therapy. Very excited about it. Here's the problem with a lot of our COVID therapies right now. Demand is huge, lots of COVID running around. Supply is really, really low. So we are really starting, we just started last week here. Most systems started within the last 2 weeks with our highest risk individuals. These are individuals on B-cell depleting therapies within the last year. These are individuals with CLL on therapy. This is any individual with solid organ transplant. Where is that? This is my own list. I can't even find it. Yeah, here we go. Any individuals with transplant, solid organ transplant on immunosuppression. So we're really trying to pick the highest risk individuals because we don't have as much drug as we want. As we get more drug, we can open it up to other things. Multiple myeloma, maybe not on therapy, things like that. But right now, we're really selecting out the highest risk individuals. So we're trying to prevent COVID with vaccination, 3 doses. With maybe if you're on immune globulin, that's helping. Evusheld. But unfortunately, people still get COVID. So what happens if you still get COVID? Now I'm going to stop and take questions. We do have monoclonal antibodies. So other than this is different. This isn't giving you COVID antibodies. This is giving you an antibody injection that binds up COVID virus. There's 3 of them that you may have heard of. This is what a lot of the politicians get, and you hear about it in the media. They were treated with the Regeneron. This is the medication. Unfortunately, these 2 medications don't have activity against Omicron. What a punch in the gut. We were using them for months, and then now I can't use them because of Omicron. So Trivimab does still have activity against Omicron. What does it do? When you treat individuals with these treatments, when they have COVID, they're not yet sick. They have COVID, but they're not really sick. They're not hospitalized. They're not hypoxic. They don't need oxygen. They don't have COVID pneumonia. These treatments decrease your viral load, which is great. It makes you feel better sooner, which is great. But the real reason we do them is because it decreases your rate of hospitalization. That's what we care about. It keeps you from getting super sick with COVID. And it's really well tolerated. All right. So when do we do this? This is in individuals who have COVID as an outpatient. This is not if you're hospitalized. If you're hospitalized, these therapies don't work. There are studies that show these therapies don't work in hospitalized individuals. They work to prevent you from getting hospitalized. All right. So that's the key here. So we're using this right now. Problem again, I mentioned drug supply very low, demand very high. This is an exciting thing. You guys may have heard of remdesivir. It's an antiviral. We've been using it in individuals for hospitalized for COVID. There is great data that it works like these monoclonal antibodies. If you use it early in COVID disease as an outpatient, it prevents progression to severe COVID. The upside of remdesivir over a monoclonal antibody, there will never be a drug shortage. It's readily available. That's great. Why don't we just go to it? Because the other monoclonal antibodies are infusions that take about 30 minutes. It's hard to infuse someone who's COVID positive. Where do you do it, right? You don't want to do it in an infusion center. There's a lot of oncology patients there. You can't do it in an emergency room. Emergency rooms are coming apart of the seams. So it's hard to do, but you can do it. But those monoclonal antibodies are a one-time infusion. Guess what, remdesivir? It's 3 consecutive days of 30-minute infusion. So it's logistically much more challenging, but readily available. So our hospital system here is in the process of operationalizing it. And I know other hospital systems are starting to operationalize outpatient remdesivir to prevent progression to severe COVID. And again, what it shows here is individuals who are treated with remdesivir early in treatment tend to get hospitalized 2 out of 279, much less often than individuals who have placebo. Really cuts down on your risk of hospitalization, which is really the goal here. And then the last thing I'm going to end with is there's now 2 oral antivirals. Same concept. This is for outpatient COVID. You've tested positive for COVID. You're symptomatic, but you're not sick yet. You don't feel terrible. You're not hypoxic. You don't have pneumonia, and you don't need oxygen. And these treatments decrease your likelihood of progression to severe illness. Paxlovid and molnupiravir, I can't even pronounce it very well. Paxlovid is absolutely the drug of choice. You want to start here. It's more effective than this one. Lots of drug-drug interactions. This one has less drug interactions, but significant concerns in pregnancy or anyone who may become pregnant. So you have to be careful. These are prescribed from pharmacies in the US. Again, drug supply is low, demand is high. So again, a lot of this comes down to just availability, but there are options. There is a glimmer of hope. There are therapies for outpatients with COVID, which is new. It wasn't like that months ago. I shamelessly stole this slide from a real mentor at NIH, Steve Holland. And the concept here is we all see things from our own prism. Oncologists are amazing at treating cancer, but sometimes they don't look around. There's other parts of cancer. There's side effects. There's immune suppression. There's infection. They are directed at treating cancer. I don't know how to treat cancer if my life depended on it, but I'm really focused on immune effects of chemotherapies and the cancer itself. So we all see what we see. If we take a step back and do it as a team, we see the whole picture. I love this study from JAMA Open Network. It says if you treat someone alone, me, by myself, I refuse to phone a friend. my chance of getting the accurate diagnosis is literally 60% if one provider does it. If I add just one more person to the team, I go from myself to 2 people, my chance of diagnostic accuracy goes up from 60% to about 75%. And then if we add team members, we get up to about 80%. So if you have an oncologist managing your CLL, they're probably doing a great job for your CLL, but have they accurately diagnosed your immune deficiency? I don't know. If you have, someone else managing your cancer, your bone marrow transplant, are they managing your infectious complications? Are they managing your immune deficiency? I don't know. So I really, really am a big proponent of a team approach, a multidisciplinary approach. I am not your oncologist, nor do I want to be, nor am I trained to be. But doing it together as a team tends to lead to better patient outcomes. And that's where the shared decision-making comes in. Everyone has to be an advocate for themselves. I've grown up on the other side of healthcare, and we certainly have to advocate for our loved ones, our family members, our friends. So it's really a shared decision. There's a provider, there's a patient, there's a family, and we talk about it. We talk about the pros and cons. We talk about if you want IVIG or sub-Q IG. We talk about what immune evaluation you deserve when you're diagnosed with blood cancer, and then we move forward. And that's really what leads to optimal patient care. So I'm going to end with that and take some questions. I hope this has been helpful. Individuals we know with blood cancer, they have immune dysfunction. And I think they should be routinely evaluated. Even in the absence of infections, individuals with blood cancer have glitches in their immune system, and checking these levels, checking these labs can help with prognosis. Infections, not cancer, is the #1 cause of complications in individuals with blood cancer. It is literally the #1 cause of death. So it is our goal, it is our job to prevent infections. Vaccinations are absolutely first-line therapy. They are not helpful, but their response is suboptimal in individuals with blood cancer and certain chemotherapies like rituximab. So we need additional strategies to decrease infectious complications, and it has to be discussed on a case-by-case basis. Maybe you don't need to do anything, just watch and wait. That's fine. I have many patients with CLL, lymphoma, myeloma that I just keep an eye on and labs and clinical status and see how they do. We do use prophylactic antibiotics. We do use immune globulin in certain individuals. And then COVID has really thrown a wrench into everything, and it's really cranked on infection risk even higher in individuals with B-cell malignancy. And your response to vaccination and is certainly suboptimal in B-cell malignancy and blood cancers. So we really have to think about protecting our most vulnerable with these other therapeutic options. Immune globulin may give you some protection. Certainly don't start immune globulin for that. I'm not suggesting that. I'm saying if you're on it, you should know you're getting some antibodies probably. Evusheld is very important, I think, and very exciting. And then therapies if you do catch COVID.
Thank you, Dr. Mustafa, for your very informative presentation. It is time for the question and answer portion of our program. Our first question is, what are the side effects of Evusheld?
Again, very, very well tolerated, no significant side effect profile. I guess the one signal was people with active cardiac disease may have cardiac issues, cardiac outcomes, but again, it was not statistically more than placebo. Something to think about. Most people don't have active cardiac disease, active heart attacks happening, active atrial fibrillation. Evusheld is fantastically well tolerated in the studies that had over 7,500 individuals, which is pretty big. One study had 5,000, one study had 2,500, and certainly in our experience locally too.
Thank you. Our next question is, if a person with leukemia didn't develop antibodies from the COVID vaccines, do they develop antibodies by actually having the illness?
What a fantastic, sophisticated question, and I don't know the answer. Maybe. In fact, likely. The problem is antibodies and T cells have memory. We know that, right? We've talked about it with these vaccines, they drop off over time. So even if you do build antibodies, I think there is probably some memory defect. So the protection is not as good as we want, but I would suspect a natural infection is going to give you some antibodies, even if you don't have COVID vaccines, but maybe not as good as you want. If you do have COVID and you have B-cell malignancy, you are still a candidate for Evusheld, by the way, for that exact reason.
Our next question is, how are leukemia patients responding to the Omicron variant despite being vaccinated and boosted? Are they requiring hospitalization?
I don't have granular data on leukemia patients. Great question. I think it's very important to note Omicron is much more contagious, but it does look to be much less severe compared to Delta. It's much more of an upper airway condition than a lower airway condition causing pneumonia. Now, of course, that's not great for our hospitals because even small percentages of huge numbers are a problem for our hospitals. So we're still seeing lots of people hospitalized. But in general, I don't want to get COVID. But if I was going to get COVID, I'd much rather sign up for Omicron than Delta, especially if you're vaccinated. So I would say the rate of hospitalization in the general population is at least half of that of Delta, if not less. I don't know the specific numbers for leukemia, but again, we're having some better outcomes with individuals with blood cancer because we have therapies now. These individuals are being treated with sotrovimab, and now they're getting Evusheld too, and now there's some oral antivirals. So there is much promise.
Thank you, doctor. The next question is, I have multiple myeloma and have low immunity. If I cannot produce my own antibodies to prevent infection, how can the COVID vaccines trigger any antibodies for me as a myeloma patient?
So COVID vaccines can certainly people with myeloma do respond to COVID vaccine, but it's certainly suboptimal. I can't speak to specific cases, but some individuals with myeloma certainly have significant defects. So again, I would definitely work with your oncologist, a clinical immunologist to evaluate your immune system, check your antibody levels, check your paraproteins, check your vaccine responses. So important.
Our next question is, I have a 9.4 antibody test result. Greater than 1 is reactive. Should I act like I have some protection from COVID?
So we have really great knowledge about evaluating immune levels to certain things, tetanus, diphtheria, pneumonia, meningitis, hepatitis. Our knowledge of a protective level of COVID is really crappy, not good. So we like seeing higher numbers of antibodies, that's fine, but we don't know if higher is better or if it lasts longer or if it's meaningful. So my example is for pneumonia, if your level of IgG is over 1.3 for pneumonia, that's protected. We know that, we've studied it. I don't know what that number is for COVID. So yeah, I think people like seeing 70 or 80 or 90 more than 40 or 50, but maybe it's all just as good. I have no idea. So that is why at this moment today, we are not recommending individuals routinely check antibody levels to COVID after vaccination because we don't know how to interpret it. Now, don't get me wrong, I do order these levels in some of my patients and they are helpful. They're a guide. If we don't detect any antibodies, that's helpful. It's disappointing, but helpful. If you detect antibodies, that's reassuring, but I can't tell you quality of the antibodies. I can't tell you how long they'll last. So there's tremendous amount to learn in our COVID antibody levels.
Thank you. Our next question is, I finished treatment for non-Hodgkin's lymphoma with rituximab 8 years ago. Would you expect the immune system to respond normally yet, or is it forever impacted?
It is impossible to know. I was taught in fellowship that your immune response after rituximab should recover after 1 to 2 years. We know for a fact your B cells go to sleep, kind of B cell aplasia in many individuals for a much longer period of time. Some people are forever impacted. The beauty is we don't have to guess. Clinical immunologists can check blood work to figure this out. You can check B cell levels, you can check antibody levels. So I encourage that to be evaluated.
Our final question for the program is, how often should cancer patients consult with immunologists or infectious disease doctors?
This depends on where you're at and who your oncologist is. Some oncologists are world's experts in clinical immunology, so you may not need to, okay? Certainly if you have oncologist who's not that comfortable with immunology, who's never checked immune globulin levels, it may help to have someone else on the team, a clinical immunologist or an infectious disease doctor with an interest in space. So talk to your immunologist. There's no right and wrong here. If you're happy with your team, the team's taking great care of you, you have the information you need, kudos to you. But again, I think this goes back to shared decision making. And blood cancers are complicated. They're complicated always. Treatments are changing. There's immune deficiency. Infections are a problem. Now we have COVID. So I think a team approach, I'm never shy to phone a friend, ask for help. So I think this is an individual discussion, but I think your needs should be satisfied. And we think we all need to be advocates for ourselves. So if you have a blood cancer and you're just treating the cancer, I think that's appropriate. But you should at least be cognizant of these immune defects and how they may play out and the very straightforward ways to evaluate.
Thank you so much, Dr. Mustafa, for sharing your expertise with us and for your continued dedication to cancer patients.
And I really, really want to thank everyone. I know how busy everyone is. I know how busy the evenings are, certainly in my house. So thank you for taking an hour out of your busy schedules to spend with the LLS and myself. I hope this conversation was helpful. You learned something. And I think, I'm the eternal optimist. And I do think there's a light at the end of the tunnel of COVID and moving out of it with not only therapies and knowledge, but hopefully with the virus kind of mutating and changing in form. So thank you so much. Angela, thanks for having me.
If we were not able to answer your questions during the program, please contact an information specialist at the Leukemia Lymphoma Society at 1-800-955-4572 from 9 a.m. to 9 p.m. Eastern Time. We also encourage you to please complete the program evaluation, which can be found at lls.org/immunology eval, or by scanning the QR code on your screen with your smartphone. Completing the evaluation will help us to continue to provide the engaging and informative programming that would benefit you the most. Dr. Mustafa, thank you again for volunteering your time with us today. And on behalf of the Leukemia Lymphoma Society, thank you for watching this program. Take care.